So we'll kick off our review with the hefty list of 7 new first-year measures being introduced with Measurement Year 2026. So we'll begin with the 4 new risk-adjusted measures NCQA is adding next year. You have to go back to public comments to see the original proposed versions of these risk measures. They were posted by NCQA first back in February 2024. These 4 measures were initially designed to be one risk measure with 4 denominators, but NCQA decided instead to split each denominator into its own measure. Each of the measures covers the risk-adjusted ratio of observed to expected unplanned acute hospitalizations shortly after an outpatient procedure, with the HFC measure specifically focused on outpatient colonoscopies. Of the 4 new risk measures, HFC has more denominator and numerator exclusions than the other 3 measures. Compared to the public comment, NCQA removed the denominator and numerator exclusions for diagnosis of pregnancy or perinatal conditions. They also separated the GI endoscopy and secondary colonoscopy procedure exclusions, which were previously a single exclusion requiring both events to be present on a colonoscopy to exclude it. A colonoscopy is considered compliant if the person had an acute inpatient or observation stay within 2 to 15 days after the outpatient colonoscopy. The numerator specs only note that the hospitalization needs to be within 15 days, but as you can see under denominator exclusions, stays that fall 1 day after the colonoscopy are actually exclusionary criteria instead of numerator compliant. We confirmed that with NCQA, numerator events need to fall within the 2 to 15-day time frame because of that exclusion. Numerator events are excluded if they have a principal diagnosis of malignant neoplasm or one of the noted planned hospital stay diagnoses. The remaining 3 risk-adjusted measures are all quite similar to one another. They measure the risk-adjusted ratio for unplanned acute hospitalizations following outpatient general surgery, outpatient orthopedic surgery, and outpatient urologic surgery, respectively. All 3 measures share the same denominator and numerator exclusions. Surgeries are excluded from the denominator for people in hospice or surgeries which are 1 day before or during an inpatient or observation stay. The numerator exclusions consist of the same 4 potentially planned procedure diagnoses. These measures all also had their denominator and numerator exclusions updated to remove the pregnancy or perinatal condition as well. NCQA introduced 2 new electronic clinical data systems measures with Measurement Year 2026, starting with follow-up after acute and urgent care visits for asthma. This measure will be officially replacing the administrative asthma medication ratio measure, which is confirmed to be retired in 2026. The finalized version of AAFE has several changes from the proposed public comment version. Eligible events include urgent care visits, ED visits, acute inpatient stays, and observation discharges with a diagnosis of asthma in any position, a change from the proposed requirement that the asthma diagnosis be in the principal position. Denominator ED and urgent care visits are excluded if they're followed by a stay with any admission diagnosis on or within 30 days after the visit. Another change from the draft spec, where previously only asthma stays would be considered exclusions. They also updated the requirements for removing multiple eligible episodes within a 30-day period to now be a 31-day period, and the updated spec has significantly increased detail as to how to deduplicate episodes depending on the associated asthma visit setting. NCQA removed the proposed denominator exclusions for acute respiratory failure and emphysema, leaving exclusions to people who are deceased or in hospice or have a history of cystic fibrosis. An event will be considered compliant if the person had an outpatient or telehealth visit with a diagnosis of asthma in the 30 days following the episode date. The public comment did not have a diagnosis requirement for the follow-up visit, so requiring a diagnosis of asthma is a new addition as well. The second new ECDS measure is tobacco use screening and cessation intervention. This measure is officially replacing the CAPS survey measure, medical assistance with smoking and tobacco use cessation, which is now retired. NCQA added a new denominator exclusion to this measure since the public comment, with palliative care now joining deceased in hospice. The draft spec for the tobacco use screening numerator previously included ICD-10 diagnosis codes to identify positive tobacco users, but those codes have been removed, and now tobacco use responses are only identifiable using LOINC answer or SNOMED qualifier codes. The people who meet numerator 1 criteria with at least one positive tobacco use response during the first 11 months of the measurement year become the denominator for cessation intervention. We confirmed via PCS with NCQA that if a person has both positive and negative tobacco use responses, they would still be eligible for the cessation intervention denominator. A person is compliant for cessation intervention if they received tobacco cessation counseling or a dispensed pharmacotherapy intervention anytime in the measurement year or in the 180 days prior. We have ongoing PCS correspondence with NCQA on how to apply this age requirement to cessation numerator events, since eligible members who are 12 or 18 years old around the start of the measurement year could be 11 or 17 years old during the prior year compliance timeframe. There are also a handful of issues with the data elements for reporting for this measure in Volume 2. We have confirmed with NCQA that the benefit data element will be removed. The exclusions data element will be limited to the tobacco use screening metric only, and a Medicare data elements for reporting table will be added in a later update to Volume 2. The final new measure to cover today is the new health plan descriptive information measure, disability description of membership. There are a couple key differences in the finalized version of this measure compared to what was provided during the public comment. NCQA has removed the age requirement for the measure, now incorporating your entire population instead of only those 15 and older. They also removed the secondary stratification for disability types, focusing the measure on just capturing the disabled or not disabled status for your membership. NCQA also added a new note about prioritizing disability status when you have multiple data sources, indicating that a disabled status should always be prioritized over a not disabled status for a member to prevent undercounting the disabled population. As with other HPDI measures, the missing disability status only reports with the no data disability status source, whereas the disabled and not disabled statuses would report with the sources of self-reported questionnaire, self-reported accommodations, enrollment status, or unknown source. We reached out to NCQA to confirm how plans should map a self-reported questionnaire response from a member of declined or prefer not to answer, to which they clarified that these should be mapped to a missing disability status with the no data source accordingly. With the introduction of this new measure, NCQA also made a minor tweak to the naming conventions of the other similar HPDI measures, replacing the word diversity with description in the LDM and RDM measure titles. All right, so we made it through the new measures for 2026. So now let's take a look at some of the notable changes to existing measures for the coming new year. NCQA has been talking for the past several years about the impending change to the layout of their Volume 2 specifications, which we finally see now in full with the 2026 specs. Alongside the spec format change, they also modified the IDSS data elements for reporting for nearly every HEDIS measure, and most of these changes are not listed in the summary of changes at the individual measure level in Volume 2. Beginning with administrative and hybrid measures, these now all have a new data element for initial population before exclusions. This element used to be limited to ECDS measures, but now it is added to most of the remaining HEDIS measures. NCQA renamed exclusion admin required to just exclusions. And they also renamed eligible population to denominator. Where that gets interesting is for hybrid measures, they already had a denominator data element to represent your sample level denominator. But NCQA did not provide a replacement data element to represent the full eligible population for hybrid measures. What this means is then to calculate the current year's admin rate, or CYAR, you need to take the initial population and subtract exclusions to use as the base for the admin rate calculation. For hybrid measures, they also renamed numerator by admin elig to numerator by admin denom accordingly. For race and ethnicity data elements, we also have some changes. NCQA has split out the Middle Eastern and North African CDC rec codes from the white detailed race value set and placed them into a new Middle Eastern or North African race category. They also renamed the Native Hawaiian or Pacific Islander category, removing the word other. NCQA renamed the race and ethnicity level eligible population element to denominator as well. So for race and ethnicity stratifications that are reported hybrid, you will no longer have separate eligible population and denominator data elements for the race and ethnicity strats. These will now only report at the sample denominator level. Changed from the public comment version, NCQA did not merge race and ethnicity into a single stratification as proposed. So for 2026, race and ethnicity remain separately reported. With the ECDS measures, we see a massive reduction in reportable data elements with the removal of the source system of record breakouts for initial population, exclusions, and numerator. There are even larger implications tied to this, which we'll get into in our next slide. Finally, even a few risk measures have some renamed elements in 2026. The measures which report non-outlier, outlier, and total member counts will now have these elements replace the word member with person. This aligns with a larger overarching change from NCQA throughout the Volume 2 spec to replace all instances of the term member with person, making their measures more easily applicable to non-health plan use cases, such as provider reporting. The term member only remains in a few places now in Volume 2, primarily in the health plan descriptive information measures and data elements. Other than retired measures, there was some additional content removed from Volume 2 that we wanted to note for you all. In the guidelines for calculations and sampling, NCQA deleted the requirement stating that oversampling rates larger than 20% need to be approved by NCQA through their PCS system. They also deleted all of their measure domain level guidelines. Some of the content from those domain level guidelines was moved directly into the corresponding measure specs, but not all. For example, the ECDS guidelines had a section called source priority, which required the prioritization of data when it existed in multiple different data sources by NCQA's source system of record hierarchy, reporting EHR data with the highest priority and administrative data with the lowest priority. We reached out to NCQA to ask, with the removal of this ECDS-specific data prioritization, does that mean that ECDS measures should now follow the supplemental data general guideline, which requires that administrative data take priority over supplemental data? NCQA's response was that no, ECDS measures are not applicable to the administrative and supplemental data hierarchy either. That leaves ECDS measures with no NCQA-defined data prioritization requirements and an open question of what supplemental data impact reporting should be for ECDS measures. We are connecting with both NCQA as well as our Health Plan Product Advisory Board on what this should look like for 2026 and invite our health plan clients to share your thoughts and feedback with us through your client representatives. Some other notable deletions from Volume 2 include the removal of most of the medication list tables from the Volume 2 spec document, noting instead to reference the separate medication list directory spreadsheet. NCQA also did away with several of their appendices, most notably Appendix 1, which detailed the summary of changes for all measures in a table format, and Appendix 7, which provided a resource for visualizing which measures shared similar requirements, such as product lines, benefits, longer claim look-back periods, and more. We maintain a similar document to Appendix 7 for plans called our mapping matrix, so we invite plan feedback as to what you found most useful from Appendix 7 that we could incorporate into our mapping matrix documentation. Looking now into measure-specific changes for 2026, let's look at the measures transitioning to ECDS reporting. Starting with blood pressure control for patients with diabetes, the existing administrative and hybrid BPD measure is not yet retired, so plans will still have both BPD and BPDE in 2026. The BPDE measure specs mirror the BPD measure in most aspects, with a few key differences. You may see larger denominators for BPDE than you see for BPD, as ECDS measures do not restrict denominator events to only be sourced from administrative data. As such, any diabetes diagnoses or medications from supplemental data sources can now cause new members to become eligible for BPDE compared to your BPD population. ECDS measures also do not segregate compliance by administrative and supplemental data, so you only have a single summed numerator data element, lessening your visibility into the impact supplemental data is having on BPDE compliance compared to BPD. The remaining three measures do not have a transitionary period where both the administrative and ECDS measures are present at the same time. Their administrative equivalents are retiring at the same time as the introduction of their ECDS versions. The lead screening in children measure is similar to the retiring LSC measure, with the primary differences being, of course, the loss of hybrid reporting, as well as the merging of administrative and supplemental compliance into a single numerator data element. The two statin therapy measures, however, are finalizing the majority of their larger proposed changes from the public comment earlier this year. These measures have several overlapping changes applicable to both, which we've listed here. Notably, similar to BPDE, these two measures will now also be able to utilize supplemental data to identify eligible members with cardiovascular disease and diabetes for their denominators. For SPCE specifically, NCQA finalized the change to remove the sex-specific age criteria. However, NCQA did not end up expanding the upper age limit from 75 to 85 from their public comment version. To close out the noteworthy changes section, we're going to highlight some additional measure level changes to expect for 2026, some of which were proposed in the public comment, whereas others are new as of the August specs. For adult immunization status, NCQA has added their proposed COVID-19 numerator from the public comment, but changed the age requirement from 19 and older to now be 65 and older. The antibiotic utilization for respiratory conditions measure had the deceased exclusion now added, aligning it with the remaining utilization well-child measures W30 and WCB. Breast cancer screening measure removed the exclusion option for unilateral mastectomy found in clinical data with a bilateral SNOMED qualifier value, but the exclusion for unilateral mastectomy with a bilateral CPT modifier is still present in 2026. The follow-up after ED visit for people with multiple high-risk chronic conditions measure has a modification to the allowable gap language that no longer allows a gap in continuous enrollment on the date of the eligible ED visit. The follow-up after high-intensity care for substance use disorder measure finalized some of the proposed changes from the public comment, including allowing numerator events to have a substance use diagnosis in any claim position instead of just principal, as well as adding the peer support services numerator option. NCQA had also proposed removing the pharmacotherapy numerator option from FUI, but the final version of the measure did not proceed with that change, keeping that numerator option for 2026. The risk measure, hospitalization following discharge from a skilled nursing facility, removed the numerator exclusion for a principal diagnosis of pregnancy on the discharge claim, similar to the changes we saw with the 4 new risk measures noted earlier. The oral evaluation dental services measure had its continuous enrollment timeframe changed from the second half of the measurement year to now be a more flexible 180 days of enrollment anytime during the measurement year. When the OED measure was first added to HEDIS back in 2023, the initial enrollment requirement was 180 days in the measurement year. But that same year's Volume 2 technical update changed it to the second half of the measurement year instead. So with this update for 2026, they're going back to their original proposed requirement from 2023. Finally, the social needs screening and intervention measure has a host of value set changes for both denominator and numerator criteria, incorporating their proposed HCPCS G0136 code into the screening numerators and ICD-10Z codes into the intervention denominators. They also moved forward with their proposed change to remove assessment CPT codes from the intervention numerators. However, NCQA did not incorporate the proposed HCPCS G codes into the intervention numerators from the public comment. They also made an additional new change to remove the age requirement of 66 and older for the iSNP and LTI exclusion, now allowing Medicare members of any age enrolled in an iSNP or LTI to be excluded. So quite a lot of change upcoming in 2026. I know the majority of you here are in the midst of starting your measurement year 2025 preparations, getting your data ready to begin your test runs using the new 2025 certified measures. And while it feels really early to start thinking about 2026, there are definitely some key takeaways from the spec that could benefit from early preparations even now. With NCQA finalizing the release of the Disability Description of Membership measure, plans should start working internally to determine your available sources of disability status data. Given this data is not captured through existing claims using value sets, this will likely be a new data mapping effort for plans depending on your available internal sources of member disability status. With the new tobacco use screening and cessation intervention measure, you'll not be able to capture tobacco use screenings and results through traditional claims sources. You may need to connect with your data vendors that translate EHR data into CCD or FHIR output to see if their mapping is capturing the section of the EHR which contains tobacco use screening results. You may also need to determine if your data mapping to your HEDIS engine would capture those tobacco screening and response codes as well. We have several measures transitioning to ECDS reporting, which will allow them to utilize supplemental data sources for denominator eligibility. To begin to understand how that ECDS transition will impact these measures, you can review your supplemental data sources for the presence of diabetes and cardiovascular diagnoses, diabetes medications, and cardiovascular procedures, which could bring new members into your eligible populations. With NCQA's alignment to OMB standards and capturing race data, plans may need to make adjustments to your current processes to collect race information to ensure Middle Eastern and North African races are separately documented. If your current race data mapping only utilizes the CDC-REC and HL7 category level codes, you should evaluate to ensure your data mapping will utilize the Middle Eastern or North African category code, which is actually located within its associated detailed race value set, to ensure your population has their race reflected accordingly. One other easy to miss change is that NCQA updated the direct reference code for some other race. This was previously the HL7 null flavor code of OTH for other, but starting in 2026, this will instead map to a CDC REC code of 2131-1. So don't forget to update your race data mapping to the new code accordingly. Plans could also begin reviewing your immunization data sources that you have today to see if those sources will provide you the COVID-19 vaccine data for your 65 and older members to be used by the new numerator for adult immunization status. And with the retirement of hybrid reporting, you may need to modify your supplemental data capture approach in 2026 to map lead screening data to the value set codes, which will be utilized by the LSCE measure accordingly. All right, thank you for joining me to review the Measurement Year 2026 Volume 2 technical specifications. We reviewed the 7 new measures, major cross-cutting updates, and several measure-specific changes to expect in the coming HEDIS season. We also highlighted key changes from NCQA's public comment draft measures and included several clarifications we received from NCQA through their PCS system. And we looked at some key areas you can begin to prepare today so you're ready with the necessary data for 2026 reporting. Hope you were able to learn something new to help you be prepared for next HEDIS, and I look forward to connecting with plans over the coming months to collaborate as we prepare our 2026 quality software for you. If you'll be making it to the Health Innovation Summit in October, stop by the Cotiviti booth and say hi. I'll turn us over to Cassie now to review the remaining webinar in our Quality Decoded series and close us out.
Thank you, Samantha. That's such great information. On your screen now is a QR code to register for the final webinar in the 2025 Quality Decoded series, featuring the experts from Cotiviti's STARS team. Also posted at this link and in the Cotiviti.com Knowledge Bank are the on-demand recordings from this entire series, including Samantha's review of the HEDIS public comment in March, the CMS advance notice and final rule, and this summer's end of HEDIS season webinar. Lastly, if you submitted any questions during the presentation today, your Cotiviti account team will follow up as appropriate. You can also send an email to answers@cotiviti.com at any time with the additional questions or for more information.